Hello, we are recording the class on complications of chronic suppurative otitis media. Unfortunately, we were unable to complete the live class. So today we will be having this recorded lecture. I hope the audio is clear and you will be able to understand the presentation. Cholesteatoma and chronic otitis media were topics covered in the previous class. I hope all of you understood and you recall the points discussed in the last class. In case you are not clear, please go through your text and the recorded lecture and understand the cholesteatoma and chronic otitis media, especially the treatment and surgeries for the same. Today's class will be discussing about the sequelae of cholesteatoma and the complications, which are divided into intratemporal, intracranial, and extratemporal complications. This division is very important and it gives a structure to your answer when it is given as a long question in the examination. Each of these divisions may be asked as a 5-mark or 3-mark question separately in the examination. Therefore, this chapter is very important from the exam point of view. The sequelae of cholesteatoma can be infection, otorrhea, destruction of the bone, of the temporal bone, and hearing loss. Complications of suppurative otitis media are caused by expansion of cholesteatoma or by spread of infection. Conductive hearing loss can occur due to suppurative otitis media, either due to erosion of the ossicular chain or damage to the tympanic membrane. The commonest involved part of the ossicular chain is the lenticular process and or stapes superstructure, and it may produce up to 50 decibel of conductive hearing loss. The hearing loss varies due to the disease extent and also presence of intervening disease structures such as cholesteatoma sac, which can also transmit the sound from the tympanic membrane to the inner ear. There can be sensorineural hearing loss due to involvement of the labyrinth. Following surgery, about 30% of patients have further impairment due to the extent of the disease which caused destruction or complications in the healing process itself. Therefore, healing loss is one of the important sequelae of suppurative otitis media. Let us move on to the complications. Intertemporal complications are complications which occur within the temporal bone. The mastoid process is one of the 5 parts of the temporal bone, and inflammation and infection of the mastoid bone causing damage to the intervening bony partitions between the mastoid air cells is known as acute mastoiditis. The damage to the air cells is caused by the inflammatory mediators, and the predisposing factors for this type of complication are immune dysfunction, well-pneumatized mastoids having large area of diseased mucosa in the mastoids in children or young individuals and due to virulent infections. Acute mastoiditis is caused by acute periostitis and osteitis by the inflammation of the mastoid part of the temporal bone. There can be decalcification and damage of the partitions between the mastoid air cells, which is known as hyperemic decalcification, leading to a condition known as coalescent mastoiditis, where due to the loss of the intercellular septae, there can be a formation of a coalescent mass within the mastoid. The inflammation triggers an osteoclastic resorption, which leads to this condition. In this picture, if you look on your left side, you can see that the bone shows loss of bony partitions. There is no well-defined air cell tracts, and it looks sort of hazy. So this mastoid X-ray, the Schuller's view of the temporal bone, shows coalescent mastoiditis. On the right side, you can see that the coalescence has led to formation of voids, which are the air cells which are joined together due to loss of the bony partitions. The clinical features of acute mastoiditis are pain, fever, ear discharge, mastoid tenderness, or which you will be taught how to elicit in the clinical posting. There will be sagging of the posterior superior external atriomeatal wall. There can be swelling over the mastoid, perforation of the tympanic membrane, in which case sometimes you can have pulsatile ear discharge, which reflects the light which you use to examine. This is known as lighthouse sign, and there can be conductive hearing loss. Acute mastoiditis is treated by using IV antibiotics. The most commonly used antibiotic is amoxicillin at a dose of 30 to 70 mg per kg body weight in divided doses, maximum of 5 grams per day. The surgical treatment is myringotomy, In case of an intact bulging red tympanic membrane and mastoiditis, you can make a perforation in the tympanic membrane to allow the pus to drain out. The surgical treatment in case of coalescent mastoiditis is cortical mastoidectomy. The purpose of cortical mastoidectomy is for complete exentation of the diseased mucosa of the mastoid air cells. Sometimes if the treatment is inadequate, that means that there is a inadequate dose or duration of antibiotic treatment, there can be slow destruction of the mastoid air cells without the acute signs and symptoms. The patient can have mild pain or tenderness, persistent conductive hearing loss. The tympanic membrane can occur, can look thick and opaque. The treatment for this is cortical mastoidectomy to remove the diseased bone and antibiotics to clear the remnant infection. If the infection spreads from the mastoid or middle ear cleft into the inner ear, the condition is known as labyrinthitis. It is of three types: acute serous labyrinthitis, diffuse suppurative labyrinthitis, chronic labyrinthitis, and labyrinthitis ossificans. Acute serous labyrinthitis is due to the inflammatory cells diffusing through the oval and round window membrane or a fistula into the perilymph. There will be formation of exudate, which is gradually resolved, followed by fibrosis. In this condition, the symptoms are less severe than in the suppurative labyrinthitis. In acute serous labyrinthitis, the condition can also occur due to post-surgical sequelae such as following modified radical mastoidectomy, where there is an inflammation in the mastoid cavity which can spread into the inner ear. Here, nausea and vertigo are the main symptoms. Sometimes there can be diplocusis and hearing loss of sensory neural type due to involvement of the hair cells. There will be spontaneous nystagmus with quick component towards the affected side initially, and as it evolves, it becomes a paralytic nystagmus with a quick component to the opposite side. Treatment will be rest, labyrinthine sedatives such as prochlorperazine, antibiotics such as carbapenem, or you can use piperacillin, and treatment of the cause such as removal of cholesteatoma. Diffuse suppurative labyrinthitis is a less common and more severe type of labyrinthitis and involves the organ of Corti. The infection can be spreading from the middle ear cleft, from intracranially, or through the blood, in which case it is known as hematogenic. Here, for the purpose of this class, we'll be discussing about the tympanogenic diffuse suppurative otitis media. Since the infection involves the inner ear, there can be permanent damage to the cochlear and vestibular apparatus, leading to severe vertigo and permanent hearing loss. The end result of this type of infection can be what is called as a dead labyrinth. Treatment is admission, IV antibiotics, rest, and symptomatic treatment. If there is any cholesteatoma or other cause of the infection, that has to be treated appropriately. This slide, look at the CT scan images. From B onwards, you can see that there is an intracranial abscess communicating with the internal artery meatus and causing labyrinthitis. Over a time, the serial CT scans were done. In E, you can see the shadow or enhancement of the fluid within the cochlea. Whereas as you progress downwards in H and K, you can see that there is no enhancement of the fluid within the cochlea. That means the cochlear fluid is lost and there is fibrosis and loss of the cochlear function, leading to dead labyrinth. Chronic labyrinthitis can also occur. It is associated with cholesteatoma, usually complicated by a labyrinthine fistula. And lateral semicircular canal is the commonest canal involved in this sort of fistula formation. It may lead to a dead labyrinth. Labyrinthitis ossificans is the final stage where there is a dead labyrinth and normal structures are replaced by fibrous or osseous tissues. The only treatment which can be contemplated is a cochlear implant in case there is an intact cochlear nerve. Labyrinthine fistula can occur in as many as 10% of cases with cholesteatoma, and the symptoms will be sensory neural hearing loss and vertigo induced by noise or change in the external pressure. It is caused by the damage and erosion of the bone overlaying the semicircular canals. Commonest is the lateral canal, and the diagnosis is by fine cut HRCT of the temporal bone. The management is by removal of the cholesteatoma with management of the matrix overlaying the fistula. Usually we are able to remove the matrix and patch the fistula with the temporalis fascia. On the left, you can see in the slide labeled A, there is a Axial cut showing the lateral semicircular canal with the eroded overlying bone and the middle ear cleft filled with soft tissue. In the slide labeled B, you can see the same in a sagittal view. Petrous part of the temporal bone is the medialmost part of the temporal bone. It is also pneumatized sometimes, and it can also be involved with infection leading to inflammation called petrositis. It can be both acute and chronic. It can be due to spread of acute mastoiditis, erosion by cholesteatoma, or spread of infection by osteomyelitis along the temporal bone. Clinical features in this are pain, profuse ear discharge, fever, vertigo, and even headache. There is a characteristic triad which is known as Gradenigo's syndrome, which involves diplopia, deep, dull retroorbital pain, and persistent oral discharge. Retroorbital pain is due to involvement of cranial nerve 5, which passes near the apex of the petrous temporal bone. And diplopia is because of involvement of abducens nerve, which passes through Dorellos canal near the petrous part of the temporal bone. Investigation is HRCT of the temporal bones and treatment is IV antibiotics. Surgery in chronic cases. In this CT scan, you can see the arrow mark pointing to the Dorellos canal which passes near the petrous part of the temporal bone. There is a cavity which is formed possibly by the coalescence of the infection. The postganglionic part of the facial nerve passes through the temporal bone and can be involved in infections of the temporal bone leading to lower motor neuron type of paralysis, which may develop secondary to acute infection or due to the slow expansion of the cholesteatoma. Temporal bone CT may be done to localize the site of nerve involvement. The most common site is the geniculate ganglion due to the disease in the anterior epitympanum. Treatment is by surgery and removal of the cholesteatoma and infected material with decompression of the nerve. Administration of intravenous antibiotics and high dose steroids helps in the management of the case. This picture shows a lady with a low motor neuron type of facial palsy. On the left side, there is a complete facial palsy as evidenced by the complete loss of movement. There is loss of the forehead crease and the nasofacial groove on the left side. You can see the movement only on the right side with a well-defined nasofacial groove and the forehead crease. Take a minute to recall the intertemporal complications of chronic otitis media. Pause the presentation and answer the question. Complications are caused by dash and dash. Once you answer these questions, you can proceed to the next part. Intracranial complications are potentially life-threatening complications with an incidence as high as 1% of all chronic otitis medias. It can be due to spread of the infection into the cranial cavity. The symptoms are usually headache, fever, otalgia, and there can also be some focal neurological symptoms. The infection can spread from the middle ear cleft into the cranial cavity via preformed pathways such as Hurtle's fissure, which lies anterior to the hole window, or petrosquamous suture, emissary veins, via the labyrinth itself or via the perineural spaces. It can also spread from the middle ear cleft to the cranial cavity by erosion of the intervening bones such as the tegmen tympani, tegmen antri. If there is a trauma leading to temporal bone fracture, the infection can spread via the fractured bone from the middle ear cleft into the cranial cavity. The infection of the cranial cavity can be divided into various abscesses, diffuse infection or meningitis, and otitic hydrocephalus. The abscesses are in relation to the coverings of the brain, therefore there can be extradural abscess or subperiosteal abscess. Here the pus lies between the duromater and the bone in the middle cranial fossa or the posterior cranial fossa. It is characterized by clinical feature of temporal headache, low-grade fever, otalgia, pulsatile profuse ear discharge. The patient can have mild neck rigidity and meningismus. Treatment is IV antibiotics such as carbapenems or piperacillin and surgery. Surgery is usually transmastoid surgery, and the contiguous abscess is drained by removal of the intervening part of the tegmen tympani or tegmen antri and allowing the pus to come out into the mastoid. The subdural abscess, in this case, the pus lies between the duromater and arachnoid mater. The patient complains of drowsiness and severe headache. There can be progression to coma. Initially, the signs can be neck rigidity, Koenig's sign. There can be focal neurological signs such as hemiplegia, aphasia, hemianopia, and ophthalmoplegia. Treatment again is IV antibiotics, which are discussed as previously, and drainage of the abscess, either transmastoid or transcranially. Surgery for the focus of infection, which may be surgery for the cholesteatoma. Meningitis is a diffuse infection of the pyometer. It is characterized by systemic features such as high fever, headache, vomiting, and convulsions. There can be signs such as neck rigidity, Brudzinski's sign or pain on flexion of the neck, or Koenig's sign, which is inability to extend the leg with the patient lying flat. There can be papilledema, reduced deep tendon reflexes, and altered consciousness. Treatment is the same: admission, IV antibiotics, treatment of the suppurative otitis media. Sometimes the abscess involves the parenchyma of the brain, leading to otogenic brain abscess. The temporal lobe is the commonest site, cerebellum is the next commonest site. Initially, the brain parenchyma is inflamed, leading to encephalitis. There is a stage of response where which is called as a latent stage, where there are few symptoms followed by an expanding abscess formation, and then there's a terminal stage where either the patient dies or there is a resolution. The focal symptoms can be there because the abscess causes focal neurological deficits such as aphasia, visual defects, paralysis, pupillary changes, and diplopia. There can be symptoms as well such as ataxia, spontaneous nystagmus, tremors, dystoidokinesia, and pars pointing in cerebellar lesions. Treatment is with IV antibiotics, neurosurgical referral for drainage of the abscess, and management of the otogenic focus once the intracranial part is managed. If the infection spreads to the vascular channels of the brain, it can lead to thrombosis of the intracranial sinuses, venous sinuses. The commonest involved sinus is the sigmoid, from where it can spread to the lateral sinus. The spread can be direct from the mastoid part of the temporal bone by erosion of the overlying bone or via the mastoid emissary veins. The pathology is there is a damage of the tunica intima due to the inflammation, formation leading to formation of a clot. This can get infected, which can spread and cause sepsis. There will be unilateral headache, otalgia, otorrhea, and high spiking fever, which is characteristically known as picket fence fever. On examination, there will be ear discharge signifying the suppurative otitis media, pitting and edema of the postoral region, which is known as Griesinger's sign due to the thrombosis of the mastoid emissary vein. Gradenigo's syndrome can also occur, which is involvement of Gasserian ganglion and abducens nerve, as discussed previously. The patient can have neck rigidity and nystagmus. Investigations are Toby-Ayers test, which shows the increase in the CSF pressure by occlusion of the opposite side internal jugular vein. CT scan with CT angiogram, MR and MR angiogram, subtraction venography, blood culture all help in the diagnosis. Treatment is IV antibiotics and for management of focus of infection, usually an anticoagulant such as heparin is added, but there is not enough evidence to support the use of anticoagulants. In this CT scan, you can see just behind the temporal bone on the right side there is enhancement of the sigmoid sinus, or on the left side there is no enhancement of the sigmoid sinus due to the intraluminal thrombus. This sign is known as empty delta sign. The rare complication of suppurative otitis media is otitic hydrocephalus. In this case, there will be a raised intracranial pressure and normal CSF. That means that there is no pus in the CSF. The mechanism is the thrombosis of the sigmoid sinus extending to the lateral and sometimes superior sagittal sinus, impeding the function of arachnoid villi and impeding the CSF absorption. This leads to clinical features of raised ICP such as headache, diplopia, blurring of vision, papilledema, and nystagmus. Treatment is antibiotics, measures to reduce intracranial pressure, including repeated drainage or passage of a drain, or we can also give medical management such as use of mannitol and acetazolamide. Treatment of primary focus is important for resolution of the disease. In this MRI scan and MR angiogram images, you can see the thrombosis of the lateral venous sinus of the brain, which is pointed out by the arrow marks. Let us take a minute to remember the intracranial complications, name them. Commonly involved parts of the brain for focal otogenic lesions, okay, are which parts? Dash, dash, and dash. Dash, you can name the parts of the brain. The extratemporal complications of suppurative otitis media are complications which occur outside the cranial cavity and outside the temporal bone. The commonest complication is the postauricular abscess, which forms over the McEwen's triangle. There is a swelling, subperiosteal swelling, and collection of pus leading to displacement of the auricle forward, outward, and downward. The treatment is incision and drainage of the abscess and management of the underlying cause for the suppuration, such as cholesteatoma. If the inflammation and infection occurs in the few zygomatic root air cells, then there is a swelling in front of and above the auricle and collection of pus. This abscess is known as zygomatic or Lux abscess. This is demonstrated in the picture, CT scan picture showing the swelling anterior to the auricle. Bezold's abscess is a type of abscess where the pus tracks from the mastoid along the anterior border of the sternocleidomastoid into the neck. The picture shows the inflammation and swelling in the neck along the anterior part of the sternocleidomastoid. Citalli's abscess is an abscess which occurs posterior and inferior to the mastoid part of the temporal bone. The pus may track along the mastoid emissary vein or occipitotemporal suture and reach the posterior belly of the digastric muscle. The treatment of the extracranial complications of CSOM again are incision and drainage of the abscesses along with IV antibiotics followed by management of the primary focus of infection or cholesteatoma. I hope you could all understand the topic well. Please go through your textbook. If you have any doubts or clarifications, you can contact me on my email ID rajivsr@rrmch.org. You can also email to the HOD in case of any problems with attendance caused by technical issues. All the best.